Good afternoon. Welcome to the CDP webinar, COVID-19, Past Epidemics and Vulnerability, Lessons for Funders Today. This is Patricia McIlreavy, President and CEO of the Center for Disaster Philanthropy. This webinar is provided with generous funding from the UPS Foundation and is co-sponsored by the National Center for Family Philanthropy, Grantmakers in Health, Philanthropy New York, Grantmakers in Aging, and the Funders Network for Smart Growth in Livable Communities. Some reminders before we get started. This webinar is being recorded. It will be available on our website and YouTube channel shortly after the webinar is completed. All registrants will be sent a link to the recording. You can submit questions at any time using the Q&A box, and they will be answered at the end of the panel presentation. If you're on Twitter, please use CDP or hashtag CDP4Recovery to share the discussion. This webinar is designed to help the funding community continue to gain more information about impacts of this virus and how to effectively respond. Our discussion today will cover what past epidemics, specifically H1N1, HIV/AIDS, and Ebola, have taught us about funding during a pandemic. The role of the funding community right now, in the near future and the long term. The role philanthropy can play during pandemics to reduce harm to everyone, but especially to vulnerable populations, and why philanthropic response matters at both the domestic and international levels. Let's look at SARS and CoV-2 COVID-19 by the numbers. As of this morning, March 26th, for those of you listening later, there have been 491,623 confirmed cases of COVID-19 in 175 countries around the world. 22,169 people have died and 118,245 have recovered. In the United States, there have been 69,210 cases, 1,046 deaths, and 619 people have recovered. To continue, by the end of the week, 21 states will have stay-at-home order in place, requiring people to leave only to access essential services and exercise. This is over 50% of the U.S. population. The states with the highest cases are New York, New Jersey, and California. The cities with the highest number of cases are mostly in the New York State, although New Orleans has the highest per capita case count in the country outside of New York. Now I would like to introduce our guest. Dr. Kristy Buccieri is an associate professor of sociology at Trent University, whose research focuses on intersections of healthcare and homelessness. She's an author and co-editor of the book Pandemic Preparedness and Homelessness, Lessons from H1N1 in Canada, which is available online. Brennan Banks is the Director of Discovery Recovery Funds at CDP, and thus a colleague of mine. From 2014 to 2016, Brennan was deeply involved in the West Africa Ebola outbreak, first as the Ebola response coordinator for the Red Cross, and then as Deputy Director of Programs for Paul G. Allen's $100 million Ebola program, where he developed and managed the Ebola response and recovery program portfolio. Liam Cabal is the Director of Grantmaking at AIDS United. Liam is responsible for the oversight of AIDS United's grant-making policies and practices, the associated grant-making systems, and the majority of AIDS United's grant-making initiatives, which are the Fund for Resilience, Equity and Engagement, People Organizing Positively, the Southern HIV Impact Fund, the Syringe Access Fund, and the Transgender Leadership Initiative. Quite a list of work there. Welcome and thank you to our panel for taking time away from their work to speak with us today. Liam, let's start with you. HIV and AIDS epidemic began in the early 80s and continues to be a crisis despite promising new treatments and research. Can you tell us what philanthropy can learn from the HIV epidemic in the immediate, short, and long term? What are your top takeaways for funders?
Thank you, Patricia, and thank you to the Center for Disease Philanthropy for inviting me to join in this very important and timely discussion. So we are currently in the third decade of the HIV epidemic, with an estimated 37.9 million people living with HIV in the world and 1.7 million new transmissions per year. In the US, it is estimated that 1.1 million people are living with HIV and approximately 38,000 new transmissions occur each year. While this epidemic is still affecting people worldwide, my focus here will be on the US epidemic and the response to it. At the time when the epidemic was recognized in the United States in the early 1980s, very little was known about HIV transmission and what, if anything, could treat it. In addition to people battling the effects of the virus, people were also battling the significant stigma surrounding it. Inaccurate information about HIV risk created a narrative about who was affected by HIV and made those affected by it deemed other. So any media attention that occurred further stigmatized people, and most governments, especially the federal government, refused to intervene. Even though HIV was mainly associated with gay men, with most attention focused exclusively on white gay men, women, people of color, and other folks who experienced marginalization were directly affected, even in the earlier times of the epidemic. The lack of meaningful attention on the epidemic in its earlier years meant many of the advancements and progress we have seen lately were delayed. Much has changed while some things have remained the same. People of color, specifically Black, gay, bisexual, queer, and same gender-loving men, Black women, and transgender women of color, as well as folks pushed to the margins, continue to be disproportionately affected by HIV. Barriers to accessing healthcare, stable housing, food security, and economic stability all increase a person's likelihood of seroconverting, which is becoming HIV positive. We at AIDS United have directed most of our grant-making resources to organizations led by people who are directly affected by the epidemic and whose efforts focus on supporting the most vulnerable communities. Next slide, please. Because of the early advocacy of community advocates and activists, many of whom are no longer with us, as well as compassionate researchers, we have had such breakthroughs as PrEP, a single daily pill that can be taken by someone not living with HIV to prevent HIV transmission, and U equals U, or undetectable equals untransmittable, which means that any person living with HIV whose viral load is not detectable cannot transmit HIV to anyone else. When talking with colleagues of mine who were involved earlier in the epidemic and who also have a background in philanthropy and preparing for this, one of the most prominent themes that arose was that the movement in the earlier years needed financial support much earlier on so that people could mobilize to convince the government to act. So that would be through creating policies, of course, but even more to prioritize research around testing and treatment. And it also meant having government leaders acknowledging that there was a public health crisis. Because at this time, government officials all the way at the top were not even willing to say the word AIDS. Educating people about the disease was also a common theme that I had heard. Funding that would have supported providing accurate and non-stigmatizing information broadly to communities across the country would have helped demystify the disease, curb the transmission rates, and could have saved lives. And finally, understanding that with most epidemics and more broadly any health issue, people who have experienced marginalization and vulnerable communities are likely to be the most negatively affected. And in this case, Black and brown communities, people who experience housing and food insecurity, and queer and transgender people are the people most affected by HIV. And if funding for organizations that serve these communities were supported earlier on in the epidemic, some of the mobilization, education, and advancements that have occurred could have happened much sooner. Next slide, please. So using the lessons of the past, there are ways we can move forward to address this current pandemic. First, prioritize vulnerable communities, especially communities of color. The most vulnerable will likely be the most harmed, and in the US, that often means poor Black and brown communities. What does that look like? Make sure that the support you're providing right now is directed at organizations serving communities of color, LGBTQ people, and people who experience housing and food insecurity. Much of the support AIDS United provides through grants and our capacity building is to these communities. The next, reduce barriers for most organizations. For most organizations, they are trying to adapt to the very quickly changing environment while still trying to meet the emerging and immediate needs of their community members. There are things we can do right now, such as creating low barrier application processes, like accepting applications by phone, changing project grants to general operating support grants, and working with grantees to reduce their reporting requirements or extend their grant periods. At AIDS United, we are in the process of implementing all of these practices. Also, community outreach and involvement. Key leaders in the communities that you support know what they need, and the partnerships that you've developed with your grantees offer an opportunity to engage those leaders to find out what needs are arising and how might you be able to assist. Reach out, but remember, it may take some time before you hear back, especially since people on the ground right now are serving communities directly, as well as personally dealing with the harmful effects of this pandemic. And finally, look to partner with fellow philanthropists or consider joining a collaborative fund. Other funders are likely to have many of the same challenges as you, and connecting with one another can help. Funders are looking to provide immediate resources to communities. With a number of new rapid response funds emerging, this may be a place where your dollars can go further and support communities' most urgent needs. Next slide, please. So we're hearing from public health experts that it may be quite some time before we return to something akin to normalcy. Because of that, we need to be thinking about how we can not only be supportive of communities, but also the staff at our grantee organizations over the long term. Based on our connectedness to communities and our experience providing support in times of great need, AIDS United is examining what long-term support for grants or for staff at our grantee organizations might look like, and even considering providing some supplemental grants that might allow for individual staff support. We also suspect that for many of us providing, providing grants to health-focused organizations, when these stay-at-home orders are lifted, our grantee partners will experience an increase in demand for services. For AIDS United, we recognize that it's very likely that people will have fallen out of care and need to be re-engaged. People may need to be tested for HIV and connected to services should that test come back positive, and more people may want to access PrEP when physical distancing is behind us. We also anticipate an increased demand for wraparound and supportive services, and that may have been, those services may have been suspended during this time, and so more resources will likely need to be directed to these organizations to meet future increased demand. We also must consider providing resources to organizations around sustainability and planning for future crises, so that should something like this occur again, we have been able to support our partners preparing as best as they can. Next slide, please. So here's some things that you can do. Be kind and compassionate to yourself and your grantee partners. We're all human, and right now, I know for me, I can use a little bit of extension of grace, and I imagine all of us can. This is likely going to be a long journey, and we need to build trust and support amongst each other. Your grantees will be more likely to share challenges with you when you've built a relationship of trust based on mutual kindness and compassion. Be understanding of the experiences your grantees and their communities are having right now and for the duration of this global crisis. Your grantees are experiencing trauma, just like communities across the globe. Be mindful of this trauma and how it may affect how your grantees prioritize their work in the upcoming weeks, months, and years. Be flexible in how you provide support to your grantees. If you're able, switch your grants that are project focused to be general operating support instead. Our grantees know better than we do how best to serve the immediate and urgent needs of their community, and giving general operating support grants allows them to put resources to best use. If you're not able to provide general operating support grants, consider how you can reduce barriers for your current grantees. Can you change grant report timelines, alter reporting parameters, maybe adjust deliverables or data requirements, or provide easier ways to access new funding? AIDS United has a great deal of experience in providing alternative forms of applying for funding and reporting, and can be a resource to other funders seeking to make similar changes. Now, I recognize that philanthropy focuses heavily on ensuring accountability. So what I'm not advocating for is no accountability, but rather new or different ways of accountability. And next slide. Finally, I want to give a huge shout out to my colleagues, Melanie Powers and Valerie Rochester, and my mentor, Maury Reardon, who helped me put all of this together. And I want to share some cute pictures of baby animals. So I know we're all experiencing a lot of stress and anxiety. And for me, looking at cute pictures of baby animals is soothing. I hope you are all doing something that helps calm your nerves during this uncertain time. And thank you very much.
Sorry about that. We seem to have a bit of a problem with some of our technology here. Apologies. Brennan, why don't we just go ahead and jump on to you. Being highly involved in the Ebola epidemic, both as a grant maker and on the front lines, you know both perspectives. When dealing with an international disaster, what should funders understand, and what are some of the takeaways you'd like to share?
Okay, let me start from the top and apologize for technical difficulties this afternoon. I'll share some of my thoughts for funders on coronavirus pandemic compares to the 2014 West Africa Ebola experience. But first, I want to note that I'm a recovering disaster manager and cannot resist the urge to discuss the current pandemic through the lens of an emergency manager. I also want to note that I'm not a global health expert by any means. I stumbled into philanthropy back in 2015 when the world's eyes were on West Africa and the Ebola outbreak. As Patty mentioned, this happened after serving as the Ebola response coordinator for the Red Cross. While at Paul Jallin's Ebola program at Vulcan Philanthropy, I was offered a very unique and insightful view into the international and national Ebola response and recovery platforms while trying to mobilize resources to on-the-ground interventions that were supporting directly individual families, communities, and organizations across West Africa. I toured newly constructed multi-million-dollar emergency operations centers in Guinea, Sierra Leone, and Liberia, met with frontline Ebola laboratories, joined burial teams in Monrovia to collect dead bodies, and met with scores of community members. Now, while there are many differences between the coronavirus, and the Ebola virus and the outbreaks, they do share some common and much needed approaches to contain spread and further prevent further infections. Some of the more notable areas where I feel a huge difference can be made to date include hygiene promotion, information, education, and communications, as we call IEC, as well as innovation. Next slide, please. First, I want to touch on the hygiene promotion. Again, at the end of the day, if everyone on this planet improves some basic hygiene functions, we could probably tackle coronavirus as well as many other common diseases around the world. Of course, knowledge of these basic hygiene practices and resources, whether it be water, soap, or otherwise, are needed to achieve this. However, if some of the least developed countries in the world could do it in 2014, 2015, 2016, why can't we accomplish the same here in the U.S., as well as other countries around the world? In West Africa, a Marshall Plan was implemented that witnessed homemade and handmade hand washing stations placed at every entrance of every building, every business, every doorway across the region. Where there was no soap or water, hand sanitizer was provided. For months, people religiously washed hands before entering any building. And I'm left asking myself here, where are all of my public hand washing stations and sanitizers across America? Just a few days ago, I went into my local supermarket and was happy to see they had a worker stationed there to wipe off all of the carts before customers came in. However, he was using a bucket that contained mostly used brown water. So I give him an A for an effort, but definitely an F for the execution. There's no reason why here in the United States we cannot have a Marshall Plan to scale up basic hygiene, really looking at hand sanitizer and soap, It's possible, the industry is there, the infrastructure is there, and this is one area that I think, again, there's a lot that we need to look at in terms of hygiene promotion, how we can better prepare our communities and families for this ongoing pandemic. Also, I would note the healthcare facilities and the issue of infection prevention and control. You know, this was a key focus area for the Ebola outbreak. Controlling the spread and maintaining trust in the healthcare system in West Africa was an important pillar for the overall Ebola response. During the early phases of the Ebola outbreak, people were afraid of going into healthcare facilities because of the fear of contaminating the virus. This forced many into hiding when sick and became a huge obstacle to identify new cases, conducting tracing, and controlling the spread. It's so important that trust and confidence in the healthcare system be maintained, and it will be tested over the coming weeks and months here in the United States. And we must ensure that our frontline health facilities and workers have the protection they need to not only protect themselves, but to protect others coming into those facilities. Everyone in this country and globally should know what infection prevention and control is and how to do it within the healthcare system, but also at the local community level. This leads me to our next slide, please. Information, education, communication. So many of our humanitarian partners know exactly what I'm talking about, and they do this around the world in almost every country that they find themselves programming in. But I think we failed to do it successfully here in the United States. Access to information is a great inequality in the United States. Access to good and accurate and timely information, even more so. How are we currently reaching those without cable news because they cannot afford it, without a local newspaper because it closed years ago, or because they use Facebook as their primary avenue for news? Ensuring that all people have access to information, education, and communications during a public health emergency is so crucial to containing the spread and preventing new transmissions. I continue to reflect at the lack of opportunities that we have grabbed here in the United States to better inform and educate the community. I remind us that it's been over 2 months since the first case was confirmed here in the US. That was January the 20th. Just this past Saturday, 2 months later, I witnessed my first television commercial or awareness campaign regarding coronavirus. Why would it take us 2 months to roll out these much needed avenues for reaching the American people and educating them further? 2 weeks ago, I was driving through a few states here in the Mid-Atlantic and Southeast, and I noticed that, you know, on our highways, we have these beautiful billboards, electronic billboards that were not being used. In most cases, they were blank because there was no traffic to report. Why aren't we using some of our current available infrastructures for reaching people, informing them, and educating them? That brings me to this highly secretive government agency that reaches all of our US-based participants on this call today. This entity is so powerful, so inclusive, that they touch nearly every US resident every day. I wonder how many people on the call today know exactly who I'm talking about. It's the United States Postal Service. And some of you might be laughing right now, but every day, the United States Postal Service places pieces of paper and packages at every US resident and business in this country. Instead of sending all of those coupons and advertisements, why are we replacing them with IEC material? Why aren't we replacing it with hand sanitizer or both for every household in America? We need to start repurposing our current assets, both government, community, and private sector, and ensuring that we're repurposing those assets to address the current needs that we have as it relates to this pandemic. We need to see how we can use these current tools and assets to better educate and better inform the general public. Next slide. Innovation. Where is the leadership for innovation? We have been watching this pandemic unfold for over 3 months, and we are just starting to talk about splitting ventilators. We must urgently adapt and or modify existing technologies and resources for the current situation and needs. During the Ebola outbreak, we had USAID providing a strong innovation coordination and facilitation role supported by philanthropy and the private sector. We need to immediately harness US and global brain power to tackle the core needs and challenges for the current COVID-19 pandemic. Again, Ebola had a massive government and philanthropic investment in innovation. We talk about PPEs. PPEs in West Africa were one of our biggest problems. It was just too hot. Workers were subject to brutal heat and humidity that required them to take mandatory breaks every 45 to 60 minutes to prevent them from passing out. The workers had to dispose of each and every set of PPE after every break, and then the process took minutes because of the full chlorine wash that was needed. So we quickly learned that in order to maintain the highest level of IPC at health facilities, especially Ebola treatment centers, we needed PPEs that were easier to get in and out of, as well as more breathable. Philanthropy noted this challenge and in return challenged the private sector, NGOs, and anyone who thought they had an idea to come to the table. As a result, years later, we have some of the largest, cheapest, and most breathable variety of PPEs on the market to date. Just for an example, how innovation during a crisis can still result in products that will have ongoing impacts and effects, positive effects on the emergency or the public health issue that it's addressing. Looking at diagnostics, for lack of better words, the science around COVID-19 testing kits is widely known and technically it's sound. However, innovation, like we did with Ebola, could help to enhance the tests, make them smaller for more mobile delivery options, offer quicker result times, design self-test capabilities, and of course, make them cheaper. Looking at vaccines, treatment, therapeuticals, obviously medical science investments are also vital. I encourage U.S. funders to not overlook investments in these areas. However, these often require large investments with a commitment to success with a higher tolerance for failure. It is science after all, but there are platforms and key stakeholders in global health to join forces and most importantly, collaborate with. Last example, drones. We are currently there are two national blood supply chain systems on two continents that use drone technology funded and tested during the West Africa Ebola outbreak under innovation challenges from philanthropy and the private sector. We have seen, again, some of these projects through innovation during emergency be used further and later on in other areas, in gray skies and otherwise. So we really need philanthropy, private sector to really step up to the plate on innovation, bring people together, have the conversations to collaborate around innovative ways. And it could be products, it could be stuff, it could be people doing things differently. But where's the innovation around how we respond to the current crises in front of us? Next slide. I'm going to be very brief to get back on schedule, and some of my colleagues are addressing some of the vulnerable populations, but I think it's important to highlight a few specific vulnerable groups that I think all of our U.S. funders should be keeping in mind. First and foremost, we remain concerned about the situation in internally displaced and refugee camps around the world. We have over 70 million of the world's most vulnerable people, either in IDP camps or refugee camps, or seeking asylum. Obviously, physical distancing is not possible in many of these cramped environments. Limited healthcare facilities and services continue to be an issue as the risks from the current pandemic start to pull away resources from other life-saving health activities. You're going to see rates of death in other areas, whether it be cholera, dengue, or other common recurring issues in those camps reemerge, and the increase in fatalities related to those issues that are not related to the current pandemic. So it's important that we shore up the support for these IDP and refugee camps to ensure they can maintain health facilities and services and try to do their best when it comes to social or physical distancing. I think it's also important to note that the funding for IDP and refugees will be affected as the world, national governments, other major donors turn their resources and attention towards the corona pandemic. So again, our refugees and IDP communities are going to be really, really vulnerable as we move forward over the coming months and coming years as a result of this current pandemic. Again, highlighting homelessness, and my colleague's going to speak to that in a moment, so I won't preempt her or echo what she's going to highlight that, but clearly the homeless population is a special vulnerable group for different reasons. And again, the low income and dependence of social services as highlighted earlier by my colleague. I'm going to wrap up there so we can move forward, but my final message for philanthropy is please go big in 2020 and 2021. And when I say go big by digging deep and maintaining your current commitments at a minimum. Your grantees, your nonprofits, your organizations, the communities that you support are going to need you more than ever during the rest of this year and probably in the coming years ahead. So please remain committed to your current portfolios and programs while looking to explore other areas where you could be doing more to support communities affected by the current coronavirus pandemic. And I'm going to stop there.
Thank you, Brennan. That's really great. I just want to highlight what's been put out there. Apologies for the technical difficulties. It does seem like Zoom is having a couple of glitches we're struggling to keep up with, but thank you for staying with us and being patient. Kristy, we're going to come back to you. I'm sorry you couldn't get through to us before, but the H1N1 epidemic had a big impact on the homeless population in Toronto. And I know people are very concerned, as Brennan just said, about how to protect this vulnerable population. What lessons and takeaways do you have for funders from that experience?
Absolutely, thank you. I think that a lot of people are looking back at H1N1 at this time, particularly to see what we learned and what we can take from it. So H1N1, as many people may remember, was the most recent pandemic outbreak prior to our current COVID-19 situation. So it was actually the second H1N1 outbreak, the first being the 1918 Spanish flu, which produced the most pandemic deaths in history. H1N1 lasted from the spring of 2009 to about the spring of 2010, and it infected approximately 1.4 billion people. And it resulted in an unknown number of deaths. We really don't have the exact count, but the highest estimates suggest over 500,000 people globally died as a result of H1N1 just about a decade ago. So we think about the messages that we hear and the messages that we're hearing right now quite a bit around COVID-19, and they are stay home, right? This is the big message of the day. And so the question really is, well, what do you do if you don't have a home? And so colleagues and I during H1N1 really wanted to know, how do we manage a pandemic for people who are experiencing homelessness? If the message is to stay home and you don't have a home, what can we then do to protect individuals who are in this way vulnerable? So the messages that I'm sharing really come out of a study that we conducted across Canada with 343 people in 2010, 2011. So during H1N1 and then immediately after. So we spoke to individuals in 4 cities and really 4 different cities to get a perspective that was varied and different according to the locations. Now we know people who experience homelessness are doubly vulnerable during pandemics. They tend to be medically vulnerable. So we know there are high rates of things like lung disease, emphysema, asthma, fatigue. There tend to be very high mental health rates in terms of conditions like depression, generalized anxiety, post-traumatic stress disorder. But we also know people experiencing homelessness tend to be socially vulnerable during a pandemic. Things like a lack of security of stable housing and income. They may be dealing with addictions issues. They often have negative previous experiences with mainstream healthcare and may be avoidant of hospitals or doctors' offices. And oftentimes they may be hard to locate. So we really need to think about, how do we protect people who are both medically and socially vulnerable during a time of a pandemic? So what did we learn? Next slide, please. Thank you. So we learned in the short term, there were some things that we really needed to focus on. And first and foremost, what really stood out was the lack of access to food that people were experiencing during H1N1. So if you look at that chart that's provided, that's information we gained on people's access to food and clean water during H1N1. So we asked people how often they were able to eat breakfast, lunch, dinner, and how often they got clean water. And what you'll notice when you look at those numbers is that people gave us figures more so thinking about it on a weekly basis rather than a daily basis. So people weren't necessarily eating breakfast each day. They would say, well, yes, I had breakfast this week. I had lunch this week. And so we want to be able to get people eating, of course, on a daily basis, on a regular basis, as opposed to having them think about whether they ate during the week. And if we look at the clean water numbers in particular, only 44% said that they had daily access to clean water. And again, this is within Canada. So this is a country where individuals should have daily access to clean, fresh water. We know that during this time, access to drop-in centers went down. And so outreach may need to be more accessible during this time. People were still using shelters, but were less likely to go into drop-ins at the time. So we want to think about how do we support communities to offer outreach services to clients who otherwise might have been in their organization, but are no longer quite as comfortable coming in. Supplies like masks, gloves, sanitizing products are in short supply, and agencies may not have the budget to purchase those supplies, or they simply may not have the space to be able to store them. And so during H1N1, one of the things that organizations identified would have been helpful for them is if they had access to a communal stockpile where they could apply or they could ask for a subsection of the supplies that were available across the sector. And really the key takeaway in the immediate considerations are actually things that my colleagues have also mentioned, and that really is the flexibility of funding. So what we heard from many of the organizations working with people experiencing homelessness was that they did in fact have funding, but they felt like they weren't able to reallocate it towards pandemic needs. And so they felt quite constrained that they had to follow the parameters that were set out for their grant and weren't able to move people around as needed. So again, I just echo that same sentiment that flexibility is really needed in helping organizations to really meet the needs of what they have to do in the immediate short run. In terms of thinking of short-term considerations, on the next slide. Thank you. We need to think about how organizations are helping people who come to seek services, and in particular, social service agencies like shelters, drop-ins, food banks, employment centers, places where individuals experiencing homelessness tend to go, tend to be congregate settings. And that means that they're not intentionally designed with public health in mind. So individuals may be in very close quarters. They tend to not have a lot of room to engage in social distancing. So this particular icon, this graph on your screen, is a question that we asked individuals experiencing homelessness. And it was, at any given time, how many people were within 2 feet of you? And 2 feet, the reason we use that is because the average human arm is about 2 feet long. And so wherever you are right now, remember you're not on camera, no one can see you, I encourage you to stick your arms out in front of you and just wave them around and see how many people you can touch. When we asked people experiencing homelessness, they said that at any given time when they were in an agency, if they put their hands out, they could touch 5 or more people. And so when you think about how disease spreads and how it's communicated amongst individuals, certainly having 5 or more people within arm's distance is not great for stopping that spread of disease. So short-term considerations, we need to invest in permanent measures that decrease disease transmission, such as UVGI air purification systems, which really work by disinfecting and working at more of a molecular cellular level. We also need to think about funding respite centers that are dedicated specifically to treat medically and socially vulnerable individuals. Shelters are not a great place to rest and recover, and so having a place that is a medical respite center would really go a long way to helping individuals in this population. Some long-term considerations. If a vaccine becomes available, we really need to make sure that individuals who are medically and socially vulnerable have access to that. And that may mean going out into the community, holding vaccination clinics in shelters or drop-ins, or even getting a mobile van and going out into public parks and doing vaccinations where people are. We know that individuals with lived experience of homelessness aren't necessarily those who are helping to inform the planning efforts. And so in between planning, we want to think about how do we include people, and from a funder's perspective, what can we do? We can actually help to fund positions where people are paid their time for giving us that sort of information, for participating and sharing their knowledge about how they navigate through pandemics. And then the last way, of course, we need to build and invest in affordable housing. We need to do that now, and we need to do that on an ongoing basis so that when we tell people to stay home, they actually have a home that they can return to and stay in long term. So the takeaway messages, really briefly out of this research, what you need to know is that first and foremost, we need to focus on making sure people have access to food and fresh water on a daily basis, not a weekly basis. We need to make sure that we permit flexibility in how funding is spent. And so we need to make sure that agencies not only have those funds, but really feel like they're able to reallocate it as needed. We need to clear the air in congregate settings and make sure that if people are in close quarters, they have a way of being able to protect themselves, as social distancing is likely not an option. We need to help people rest and recover, provide them with some sort of place where they can get away, where they can rest, and that understands the vulnerability that's inherently part of experiencing homelessness. And then finally, how do we avoid this going forward? We need to develop affordable housing and make sure that that's the kind of investment that we are making in the long term.
Thank you, Kristy. That was very interesting. I'm going to take a little bit of time now to try and capture some of the questions that are being asked, and to see, we had some questions sent in advance. And a few thoughts, there are a few comments coming up in the Q&A related to prison environments, and immigration detention centers and congregation of populations that we're trying to help and serve. And I think also not connected to this, but somewhat highlighting as well, not to forget that vulnerable populations go beyond the categories that we've already highlighted, that there's also people, living with disabilities, which is another category of individuals we need to really make sure we're attending to. So I guess just a general question, maybe Brennan, for you, since you've had this experience of the Ebola response, how do you balance the need for relief to a vulnerable population while also recognizing that some of the ways of providing relief traditionally have been create crowds, that by definition, there's a certain level of connectivity that comes with that? I mean, what would be some propositions you would have to addressing this current crisis with attentiveness to that crowding mechanism that is there?
Hi, Patty. Thanks for that question. It's a really important question. And I think the answer is that there's different ways of addressing that. And it's really going to be specific to the environment, the community, the context that you're operating in. But at a minimum, I think what's most important is that you are identifying community groups or infrastructure within the community. It could be the church, it could be a community center, it could be government, otherwise. But identifying a entry into the community or a partner within the community that could act as the receiving host or recipient of those relief services, activities, or interventions, and helping them to facilitate that, so you reduce the contact between, let's say, persons from outside the community versus persons from within inside the community. So you want to be able to identify a community contact or asset to work with and let them be your avenue or reach into the community. And then two, you have to look at creative ways, again, of sort of reducing that contact within the community as well. So, if it is, traditional distribution of non-food items or other material resources, then you need to look at creative ways to come up with more flexible scheduling so that you're not having 100, 200 people arrive at the same time. And there's different ways of doing that, from, staggering the scale and inviting people to come to you, using multiple targeted distribution locations. But again, it depends on the context, the community, the environment, and of course, it depends on what type of intervention you're trying to bring into that community.
Great, thank you. Kristy, I'm going to come over to you now. I mean, interesting in terms of the proposals you had for how to manage, building safe housing, finding ways that populations can stop being, that they can have the options to have a home in which to look at managing this? I mean, the other aspect of that we have is, Brennan already mentioned, how are we using the social good to get the message out through the postal service? I mean, you see more and more newspapers, for example, making their coronavirus information free online. But there's also the healthcare. And I'm asking you this specifically coming from Canada and looking at the US. I mean, we obviously have a lot of healthcare and health access disparities. And I'm just curious, what resources would you advise that we would need, to ensure in terms of our precarious health system and how to address it being able to build back better in a way from where we are right now?
Yeah, it's an excellent question. And I think certainly when there are vulnerabilities, those vulnerabilities tend to exist and get worse during a pandemic outbreak. And there is a tendency to focus on those vulnerabilities or the pandemic, perhaps more so while it's active. But I think what we really need to take from this is that if we were to address the vulnerabilities during non-pandemic times, they wouldn't be quite as extreme when an outbreak hits. So what I think we really need to do is we need to focus on those social factors, those social inequities that contribute to creating vulnerability in the first place. And we need to incorporate them into our healthcare approach. And they're things that we may not necessarily associate as being healthcare, things that we may not necessarily fund regularly through a healthcare stream. Things like transportation, things like a guaranteed basic income, access to childcare supports. These are things that really will help people to become more healthy, that will help to erase some of the inequities that we see in our healthcare outcomes. So if we learn from these pandemic times, and if we know who is the most vulnerable during these times, and we work to build a system where we reduce these vulnerabilities, then when the next pandemic hits, we'll find that that impact is not quite as great, that they're not quite as negatively impacted because we've already built into our system safeguards to protect them and to keep everybody healthy. So my response would really be that even though we are perhaps more inclined to focus on them during a pandemic, we need to think more so during non-pandemic times of how do we just build our system in such a way that we have those supports already built in, so that if the worst happens, if a pandemic happens, we're prepared for it and we have populations who are healthy.
That's a great answer, reminding us all that we have to not only look at today, but look at tomorrow and how do we protect these populations in the best way possible in terms of how we look at these programming. Liam, I want to bring it back to something you actually spoke a little bit in terms of touching on the treatments. One of the questions from the group is commenting on services for vulnerable populations, specifically the disabled and the elderly, who require medication, either for mental health or substance abuse treatment. How can we assure that these populations still have access to the medications they need if they're not able to go out, if they're not able to possibly access them, or worse, if the pharmacy is running low on supply, as we've heard about a few different things, especially related to lupus? What are some of the suggestions you would have to managing that? What can we do?
Yeah, thanks. I would say that I'll use some of the things that are what we're hearing from grantee organizations and individuals specifically living with HIV. We have been encouraging folks, and they've been having some success on getting a 90-day supply of their HIV medications. And then there are lots of pharmacies that are doing the ability to switch your pickup to be mailing. I think that's not to be like mailed to you, rather. I don't think it's necessarily happening universally. I think that some of the things that we can be thinking about in the experiences of our grantees, I don't know how many folks are necessarily supporting advocacy right now, but advocacy most certainly looks different depending on the situation and who you're contacting, but arguing for more accessibility to medications that can be mailed to the individual, and then making it easier for insurance companies as well as other healthcare or health insurance providers to allow for advanced or multiple months ahead supplies of medications. That's definitely something that folks are encouraged to do now as it relates to their HIV medications. And so I would say that in any case, with whether it's another chronic health condition or HIV, being able to connect to your healthcare provider to get access to a longer, many months supply. And on top of that, I think that there's a possibility to kind of consider, especially since a lot of, we're hearing a lot of providers that are providing health in direct contact are switching to a telehealth model. And so, and we're hearing that from mental health providers as well as folks who are providing care where they don't necessarily need to be physically present. But those are kind of the things that we're hearing from the field right now. I think that there's still so much that we're trying to learn and get information from the field around.
Feels like we may have lost Patty again.
Sorry, apologies. No apologies, I'm here. I just wanted to say in the conscious of time and just want to ensure that looked at the questions that are here and want to be respectful of everyone. A lot of the questions that are left are connected to how to get funding, how to recover funding for lost events or financial losses that are going on right now. And I think that there have been some advice given already from the participants related to that in terms of really having a lot of flexibility, asking the philanthropic community to be open to exploring that and looking into it. I mean, there's many things we need to do as a community and kind of calling this out and making it clear. And just want to, definitely recognize that there was also a question here related to having to plan differently for the future. And I think that also has been touched on. And I really want to thank the panelists for their discussion. So I'd like to summarize some of the discussion, provide with a couple of other key takeaways. One, just really great message from Liam, be compassionate with yourself, be compassionate with your grantee partners, and recognize this is a really hard time for everyone. Meet the basic needs, food, water, sanitation, hygiene, and income. I mean, that is already an enormous ask of our community, those things, but really to keep a focus on the whole of an individual and how do we help that in the best way. This is a marathon, not a sprint. So, pace yourself, but also recognize that money needs to get out the door quickly. So how can we really help in the best way possible, either as donors, or also as recipients of grant money to how are we getting funds to the populations that need them the most. Fund now and fund later. I think it's one of these things where I feel, I'm hoping we don't hear just in a few months that there's a donor fatigue because this is a long race, as we said, a marathon, and we really need to keep everyone focused on it, and it's going to require all of us to be as generous as possible, as Brennan mentioned. Be flexible in how funding is spent when setting expectations, deadlines, outcomes, and timelines. Go big in 2021, dig deep, maintain your commitments at a minimum. And I would just add to this, this isn't the only crisis that's out there, and that's been highlighted by others and on the panel. It's really remember that it can't all be for COVID-19. There's going to be a lot of other crises impacting people, and we need to ensure that we're looking with a broad enough lens to capture all of that, while at the same time being attentive to the impact COVID-19 is having on everyone. As our panelists have shared, there will be ongoing needs to assist with recovery efforts over an uncertain length of time. CDP and its partners at Candid are tracking philanthropic donations to this outbreak. As of March 25th, the total donations received stood at 2.9 billion. Want to just highlight that billion. It's a big number, but it's probably still not enough. We are looking at an incredibly large geographical area, and so we need to not compare this to things like, well, we raised several hundred million for this response, and that's 2.9 billion is a lot. Remember, 2.9 billion is going to go up because the scale of this is enormous, and we still need to be generous, not responsive to that and thinking that that's been enough donated. CDP has many resources. There were a few questions on the Q&A about how do I get more information. Look at our website. We also have a COVID-19 response fund donated to Disaster Philanthropy that can assist. For more information, you can find out about our work at disasterphilanthropy.org. Our staff are always on standby to help and to provide guidance. And to those of you who may be planning disaster response funding, CDP has additional information through the Disaster Philanthropy Playbook. You can find this resource also on our website, disasterplaybook.org. In order to respect everyone's time and keep this, I'm going to close it now. Thank you to Liam, Kristy, and Brennan for taking the time to share their insights. Special thanks again to the UPS Foundation for hosting the webinar, and to our co-sponsors, the National Center for Family Philanthropy, the Grantmakers in Health, Philanthropy New York, Grantmakers in Aging, and the Funders Network for Smart Growth and Livable Communities. Thank you to everyone who joined us. As the webinar ends, a brief survey will pop up. Take a moment to share your thoughts. Apologies again for our communication challenges we had on this. It's not usual, but I do think we all need to be patient in work in the time of COVID-19. Thank you, stay healthy, and have a good afternoon.